My name is Megan Gleason. Today I'll be talking about management of cartilage injuries in the knee. So at first we're going to go through cartilage anatomy and different types of cartilage, and then talk a little bit more about injuries, how we grade them, and then treatment options. We'll go through different factors that we consider with our patients, as well as some non-operative treatment, and then we'll get into some of the operative indications for different types of cartilage injury. So specifically, we're going to be looking right at the knee. This is an area of orthopedics that we deal with frequently. Cartilage itself is a special kind of connective tissue. It transmits loads. It has a low coefficient of friction, which means things slide very nicely over cartilage. Cartilage is an interesting tissue, though, in that there's no blood vessels, there's no lymphatic system, and there are no nerves within the cartilage. Unfortunately, this also means that it has a very limited capacity to heal when there is a specific injury to this area. Cartilage gets its nutrition specifically from the surrounding synovial tissue, or synovial fluids, and so we are very reliant on having a good supply of synovial fluid to allow cartilage to both heal and to grow. There are different types of cartilage throughout the body. The three that I'm going to talk about here are hyaline cartilage, elastic cartilage, and fibrocartilage. Hyaline cartilage is smooth, and that's what you're going to see within the joints of the body, specifically within the knee. It allows sliding and gliding. It's tough, but it's also very flexible, and it's probably the most common type of cartilage you're going to see within the knee. Elastic cartilage is also a cartilage you'll think about within the body. It's supportive and flexible. That's something more you're going to see like the cartilage within the ear. And last, we'll talk a little bit about fibrocartilage, which is the toughest type of cartilage within the body. It's very supportive, but it's also rigid. This is the type of cartilage you'll see within the meniscus, around a fracture callus when you have a broken bone, and also within the discs of the vertebrae. On this slide, we're showing different types of cartilage and their structure on the microscopic level. So cartilage injury. When someone comes in with a cartilage injury within the knee, we think about it in two specific ways. One, is it focal or is it diffuse? People with arthritis have diffuse cartilage loss. A lot of times, though, we will see a patient who has a very focal or very specific injury in a very narrow area. When that happens, we talk about grading it or classifying it, and we use something called the outer bridge classification. Normal cartilage is a grade 0, and then we go 1 through 4 depending on the degree of damage. 1 is where it's, I'll show some pictures. Grade 1 is where it's slightly soft. Grade 2, it's a little softer with some what we call fissuring, and then all the way to grade 4 where you have full thickness loss down to the what we call subchondral bone. And that's really what we refer to as a full thickness cartilage loss. So these pictures show some example of progression of cartilage injuries within the knee. When you have advanced arthritis, you really lose cartilage diffusely throughout the knee. So on this photo, we're seeing loss of cartilage both on the femoral condyle and the tibial plateau. This is not what we refer to as a focal injury. So if you have a patient who has diffuse cartilage loss, this is not something that is necessarily amenable to a cartilage replacement procedure or cartilage healing procedure. So when we talk about these injuries, we often talk about size, and 2 centimeters squared is really our cutoff for small or large. We talk about the stability. Is this something that can be repaired, or is it something that's unstable? In some pediatric patients, we'll see cartilage injuries that can be repaired. And then we also talk about the location. Is it in the condyle of the knee? Is it in the trochlea? Is it on the back of the patella? So these are all very important factors when considering options for treatment. We also think about patient factors. Are there any other injuries? Did they tear their ACL at the same time? Do they have a meniscus tear? Or do they have a kneecap that easily dislocates? So these are all important things when we talk about treating the patient as a whole. We also want to look at the patient's alignment, their age, their body weight, and their activity level. What are they looking to get back to be doing? So we talk about non-operative management. Obviously, if someone is overweight, dropping their weight can be beneficial. Anti-inflammatories can be helpful. Physical therapy, and then consideration of injections. So, icing, anti-inflammatory management is often the first line of treatment. We talk a lot about supplements. Glucosamine chondroitin is a popular one. There's no founded studies that say this really makes or breaks someone, but it's often something that people will try. Different types of injections. We can talk about steroid injections, hyaluronic acid injections, PRP injections, stem cells. Again, these are management plans. They're not necessarily going to help rejuvenate the cartilage, but they may help manage symptoms. And this is an example of some of the PRP type injections that we can use. When we talk about surgical options, the simplest thing that you can do is something called a chondroplasty, which is basically where you go in and you smooth down damaged cartilage. It helps to prevent propagation. People usually recover very quickly, but it's really ideal for small lesions, and we allow patients to really get up and get moving right after. There was a study a couple years ago that showed NFL players did well returning to play after a chondroplasty as long as they had no other injuries. And so essentially it's taking an area with damaged cartilage and smoothing it down. Next, we have something called a microfracture. This is where we poke small holes in the subchondral bone to access bone marrow, and this allows hyaline cartilage to be replaced with fibrocartilage. This is really only a good option for smaller lesions, and there is some limitations to the rehab afterward. Patients can't walk right away. So essentially you have a small lesion in the cartilage like we see here, poke a couple little holes in it, it causes some bleeding from deep down, and this area will essentially scar in with a new type of cartilage. It's not the same kind of cartilage, but from a symptom perspective, it can be very helpful. Next, we talk about transferring osteochondral pieces. So that's essentially taking a piece of cartilage and bone. We harvest it from an area of the knee where it's a non-weight-bearing zone. We can use up to 6 to 10 millimeter plugs. We kind of press fit them into the area where the damage is. And this actually works well as long as it heals and the patient is compliant with their post-op restrictions. Again, this is better for smaller lesions. We liken this to using a cutter to get the hole for a golf hole. So essentially what you're seeing on the upper right side of the screen is a piece of bone with the hyaline cartilage attached to it. We take it from one zone and we transplant it to another zone. So these are some examples. On the upper right is a flap of cartilage that was not amenable to repair. You see it kind of trapdooring on the upper right side of the screen. And then on the bottom of the screen, we're seeing where the cartilage has been replaced with plugs of osteochondral donor tissue. And these come from the same patient, so this is all done at the same time. This is another example. You have an area where you have full thickness cartilage loss. You replace it with a plug of cartilage and bone. When the lesions become larger, and they're not amenable to using your own tissue, we'll use donor tissue. These can come in the form of plugs, or they can come in a hemicondyle, meaning a partial knee. These are better for really large lesions that don't have good boundaries, and often are sometimes used in a revision setting as well. These are some examples of donor tissue, which is used in the setting of filling in lesions where there's been larger areas or where they haven't been amenable to repair with their own tissue. This is an example of a hemicondyle where we take a large section of bone and cartilage and then transplant it into the area of the deficit. Another example is what we call particulated juvenile chondrocytes, and that's where we use immature chondrocytes that are donor tissues, and those are very good for areas that need coverage but don't have great boundaries or the contouring is not easy. Again, this is for larger lesions. You're often going to see this in the patellofemoral joint. So here's an area on the back of on the front of the trochlea. And on the right side of the screen, you're seeing where these juvenile cartilage cells have been implanted and then glued into place, and they will propagate and fill in with hyaline type cartilage. Last option for cartilage repair is something called autologous chondrocyte implantation. This is a technique that has really shown great promise, where we essentially take cartilage from the patient, grow it up in the lab, and then go back and do a second procedure to reimplant the patient's own cartilage cells into their cartilage injury. The downside to this is it is a two-stage procedure, but we are using the patient's own tissue and own cells in order to repair a deficit. So I'll show you some pictures of this. Essentially, you have a lesion. You take a cartilage biopsy from an area where cartilage is not needed within the knee. That gets sent out and grown up in the lab. Come back usually between 6 and 3 months later. You have an area where you'll clean up your cartilage damage, and then you'll have a membrane that gets affixed down to the area of the cartilage defect, and then that will propagate and grow. And then finally, we talk about knee replacement. If the cartilage damage is too diffuse and it's too involved, then unfortunately a lot of these cartilage repair procedures are not an option, and we turn to arthroplasty. Depending on the location of the lesion, that could be a partial knee or a unicondylar knee arthroplasty or a complete total knee arthroplasty. Thank you.